Okay, we're going to give you a little run through on the endocrine system just to fill you in so you get a little bit idea what the endocrine system is all about. Probably because we have talked about it earlier in this semester when we talked about the neurological system. We talked about when how the importance of the body likes to work within homeostatic limits, and we go outside that. Sometimes the nervous system will have a very rapid response. The nervous system responds quickly by making very rapid changes. The hypothalamus senses everything and sends out a signal, but sometimes we need something that's maybe a little bit delayed but a little bit more sustained, and that's through the endocrine system, where the nervous system sends a signal directly from the brain through a nerve to an area that causes a response. The endocrine system is different. It goes through multiple steps, and I'll explain what those steps might be, where we sense something abnormal, it sends it to something else, it sends it to something else, and finally it causes a change somewhere in the body by the secretion of materials called hormones from various endocrine glands that we have in the body, and they circulate around the body and then cause an effect because of that. So as a result, the endocrine system has a tendency to work a little bit slower than what we find in the neurological system. Rapid changes, neurological system, nervous system, a little bit more slow, but sustained changes, endocrine system are probably better for that. So we're going to do a real quick run through in regards to what the endocrine system is all about, and hopefully you'll understand a little bit more about the interface between the two. So again, getting back to what we were talking about, we know the endocrine system works with the neurological system. They're two interlocking systems. They both rely upon each other to do what they need to do. And again, they control a lot of many of the activities of the body, but as with the nervous system, the whole prime responsibility is for homeostasis, to keep the body in that homeostatic control, which is what it's all about. Okay, a couple things about the endocrine system. First of all, the endocrine system consists of a number of ductless glands. Now, what I mean by a ductless gland is that what happens is, if we look at the pancreas is exocrine, because exocrine means that they make enzymes, and the enzymes come out of duct and they secrete it into the duodenum to help in digestion. But the pancreas also is endocrine, and there are certain parts of the pancreas that are called the beta cells, or islets of Langerhans, that make a hormone called insulin. And instead of taking that insulin and putting it out a duct into another organ, what it does is it creates what are called hormones. And these hormones are then put into the circulation, and the circulation is discharged to go out throughout the bloodstream to hit other target organs where the effect will produce some type of response to again get back in that homeostatic control. So that hormone is secreted out of the endocrine gland to go elsewhere in the body to provide some type of a specific effect. As a result, what happens is I have a series of linkages that I have. What senses the problem, that sends a message to something else, which then sends a message to an effector organ, which is basically the gland, which then sends out the hormone to a target organ, and the target organ then will provide the response that you need. So it does take a little bit of time. There's multiple steps that we need, and what happens is then this is regulated by what we call feedback, and I'll give you a little chart and show you what this feedback does. Because what happens is I want to create a change, and it creates a chemical change or whatever the case is in the body, and that gets fed back to the original place where this whole system starts, and if it's enough, it shuts it off. So all of a sudden, boom, we're back at normal, and we could take the foot off the gas now. Okay, if it's not enough, it'll continue on with that whole process where we make more hormone until we finally get normal and get to where we have that homeostatic control. And that prevents sort of like an oversecretion or an undersecretion of a gland. And I'll explain that a little bit more. And that's what we're talking about here. Let's start with the image on the left. It says stimulus, sensor, control, and effector. Let me just tell you how this goes. Let's say there's something that's out of whack a little bit, okay, and that's picked up in that stimulus area. We find something's wrong. So what happens is, how do we know something's wrong? Well, first of all, there's a sensor, and that sensor frequently is, let's just take for an example the hypothalamus. We talked about the hypothalamus is constantly sampling anything. So the hypothalamus samples something that's wrong. There's some stimulus. It says this is not right. We have to correct it. Hypothalamus says, you know what? That's right. We have to correct that. So what does the hypothalamus do? The hypothalamus then releases something called a releasing factor. It sends a signal through a chemical down to somewhere else, and frequently that place that does that control would be in the pituitary gland. So the hypothalamus realizes something's wrong. It sends out a chemical called a releasing factor to the pituitary gland, and the pituitary gland is called the master gland because it controls a number of other endocrine glands. So what does the pituitary do? It says, yes, boss, I'll take care of that right away. And what the pituitary gland does, it sends out one of a number of different types of pituitary hormones according to what the response would be. So that gets in the circulation, goes all over the body, okay? And all of a sudden, there's a certain organ which is called a target organ that wants to produce that effect. And let's just say that target organ here might be the thyroid gland. So all of a sudden now, this pituitary hormone, called, if it's the thyroid, it's the thyroid stimulating hormone from the pituitary, gets to the thyroid, and the thyroid says, oh, got a message from the foreman above that says we need to send out some thyroid hormone. And what the thyroid does, it sends out that thyroid hormone, sends it into the blood, and the thyroid hormone gets into the blood, and what the thyroid does, it controls metabolism. So it's going to either increase or decrease the metabolism. So now what happens is it sends out this thyroid hormone, which is going to be called T3 and T4, which I'll explain later on. And lo and behold, if it's enough is secreted, we're back to normal. And when we're back to normal, we don't need to have the hypothalamus recognize as something, because now everything's back to normal and it stops that signal from the hypothalamus on down, and now I'm back in that normal range. And that's called a negative feedback. Once I'm back to correct, back to normal, this whole system stops. So I don't need to send out a releasing factor. I don't need to send out another pituitary hormone, and the thyroid doesn't have to send out any more thyroid hormone because I got it back to where it's supposed to be. And that's called a negative feedback. And if I look at the image on the right, it sort of shows what we're talking about. If we have a body condition where if you look at the top, if something is too high, okay, what happens, the signal sent out to a particular gland, frequently the pituitary gland, which sends out a signal to another gland that sends out a hormone, and that hormone will lower the body condition and to get it back into normal. On the other hand, if I look at the bottom part of that curve, if something is low, again, we have a gland that sends out a hormone. That hormone corrects the problem by a target organ, raises the body condition, and we're back to normal, and it shuts itself off. So that's that way we don't over-secrete or we don't under-secrete or over-correct or under-correct. We get the right amount of correction by what's called a negative feedback system. Now, what are some of these main endocrine glands? Okay, if we look at that, there are a number of glands here. Some of them have a lot more influence and some of them don't have a lot. Pituitary gland. I'm going to mention the pituitary gland because the pituitary gland is often called the master gland. And it is, but the master gland has a master, and the master is the hypothalamus. The hypothalamus generally tells the pituitary what to do. Okay, so we'll talk a lot about the pituitary gland and the number of hormones. There are a number of hormones that are secreted by the pituitary gland, about 8 hormones, some of them from the front of the pituitary, some of the back from the back of the pituitary gland. There's what's called the pineal gland. The pineal gland is a small gland that's in the middle. It's buried deep in the brain. Okay, and there's a little question as to what it does. We know that it does secrete, melatonin, which is involved in things like sleep and stuff like that. So we won't talk too much about that because that's not all that critical. Thyroid gland. Thyroid gland's in the neck. We talked about that when we talked about the respiratory system, how it sits over the top of the trachea. It's like an H-shaped organ that sits just below the thyroid cartilage over the top of the trachea. And the thyroid gland is really responsible in controlling body metabolism. Body metabolism is how fast the engines are working in my body. If some people who are hypothyroid, the engine's working a little slow. Other people who are hyperthyroid, their metabolism is too sped up. It doesn't show it on this image right here, but on the back side of the thyroid gland are 4 to 8 small little nodules, and these are called the parathyroids because they're right next to the thyroid gland and they're attached to it. And these actually control calcium. We talked about it when we talked about the urinary system, how sometimes, and also in the musculoskeletal, particularly the osseous section, we know we store calcium in the bone, makes the bone strong, but we know we need calcium a lot more for muscle contraction, nerve conduction, cardiac muscle contraction, and things like that. So if my calcium level in the blood goes down, what do? It sends a signal to the parathyroid gland. The parathyroid gland secretes a hormone called parathyroid hormone. I don't know where they got that from. Parathyroid hormone, or PTH, and the parathyroid hormone actually goes and does a couple things. It takes the calcium out of the bone to increase the blood calcium. It causes the gut to increase the absorption of calcium in the intestines, and it also decreases the renal excretion. All three things help to raise the level of serum calcium, which then gets it back to normal. So those are called the parathyroids. There's also one that actually will lower the calcium, that's calcitonin. Okay. Below that we have the thymus. Okay. Now the thymus we don't think a whole lot. And remember, you got to talk about it. The thymus in babies is huge. In adults, it gets much smaller and smaller and smaller. It's a place where basically more for maturity of white blood cells, but that's about it. Let's go down now and talk about the adrenal gland. The adrenal gland are also called the suprarenal glands. They sit right on top of the kidneys. Okay. And these are important because they have a renal cortex. We talked about in the kidney, the cortex is always the outer portion of the organ, and the medulla is on the inside. That renal cortex makes things like cortisol, aldosterone, a number of significant hormones that do a lot of good things. Okay, and the inner portion creates norepinephrine and epinephrine on the inner portion on the medulla, and we'll talk a little bit more about that. We've already talked about the pancreas in the gastrointestinal system. In the hormonal section, basically the two major hormones. There's a bunch of hormones that the pancreas produces, but what we find is in the pancreas, the biggest hormone that it produces is going to be insulin. Insulin, then when we eat and the carbohydrate levels go up in the blood, the glucose levels, I need to get that glucose into the cell for energy. I need that with insulin. Insulin needs to open up receptors, or binds to receptor and opens up a door on the surface of cells to let the glucose get in. If I don't have the insulin, it doesn't get in. So insulin tends to decrease blood sugar, and the other one that's major in there is called glucagon. If my blood sugar is low, the pancreas secretes something called glucagon, and it raises the blood sugar. We also have the ovaries and the testes. We have factors that come from the brain, from the pituitary, that actually stimulate the ovaries and the testes to produce their hormones. In the ovary, the primary predominant hormone is going to be estrogen, okay, that's being produced. And maybe we'll get a chance to put a video together sometime in regards to how the female reproductive system works. And then we also have the testes, and the testes primarily are the manufacturing spot for testosterone. The adrenal gland also makes testosterone a little bit, but not as much as the testes, okay? And also, estrogen and testosterone are really close. Estrogen can be converted to testosterone. Testosterone can be converted to estrogen. So these are just some of the glands we have. I think I have another picture of these glands coming down the road as well. So when the hormone, when the control of the hormone is there, okay, when the hormone is released, it causes it's there because of response to something. If something is abnormal in levels or there's a malfunction, then these hormones are released. What this does is it does create some possible problems, okay? When these endocrine glands all of a sudden malfunction for some reason, either they make too much hormone or they make too little, or they act indiscriminately, they're giving out hormones when they don't have to, that causes some problems and produces various conditions and disorders. And I'll touch a few of those as we get later on down in this particular video as to some of the disorders that may occur with when we have an abnormality or malfunction of these endocrine organs, okay? As a result, what happens is sometimes we have an organ that doesn't work, okay, and as a result the hormone levels are decreased, and that's going to cause a negative effect on the body. Or sometimes these organs will secrete too much hormone, they become overproducers, and as a result that will also cause a problem with the body. And I'll talk a little bit about those as time goes on. And again, these are just, again, another the endocrine glands. Again, the pituitary, the master gland, we'll talk about. The thyroid, we'll talk about the parathyroid gland, we'll talk about the adrenal, we'll talk about the pancreas, we'll mention a couple of things about the pineal, and right now we're probably not going to say much about the thymus as well as the testes and ovaries. We'll leave the testes and ovaries, or testes and not ovaries, but testes and estrogen for later on, for the testes for testosterone and ovaries for estrogen later on. We'll talk about those in another reproductive system video at some other time, okay? So those are the main organs that we have in the endocrine system. This is just another picture looking at the same thing. There's a pituitary gland sitting up there. The pineal gland sits deep in the brain. We see the thyroid on the back side. We get those parathyroid glands. We can see when we look at the image. Let me get this going here. If I'm looking in here, here's the little parathyroid, here's a little parathyroid right there, little parathyroid right there. So you see them on the back side of the thyroid. They're very small, okay? The adrenal glands sitting on top of the kidneys here, on top of the kidneys. Here's the pancreas, ovary, testes, and we'll be talking about those, okay? So enough of that stuff. You know what those glands are, where they are and stuff like that. Let's talk about those individual glands by themselves. Let's first talk about the pituitary gland. Again, the pituitary gland is called the master gland. Now, we know about this a little bit. We've already talked about it, and we've talked about it a couple times during the semester already, okay? We've talked about it in the osteology section, because when we look at the skull, the pituitary gland, which is also known as the hypophysis, sits in that little hypophyseal fossa right between the anterior cranial fossa and the middle cranial fossa, right behind where the optic nerve crosses at that optic chiasm. If you remember that with the sella turcica area, basically that's where the pituitary sits in there. It sits in that little depression, and there's a little membrane that covers it and holds it down in that little depression. And through the membrane there's a little hole, and through that little hole is a little stalk, and that little stalk is a neural stalk which is called the infundibulum, that goes up to the area of the hypothalamus, which sits right above it. Okay, and it's about the size of a pea, about the size of the tip of your little finger, and it's at the very base of the brain, almost like right behind the eyes, as you would see looking at the skull from the inside. And it secretes a number of hormones. Okay, now they divide the pituitary into what's called the anterior pituitary and the posterior pituitary. How in the world can you say a pea-sized thing could be divided into anterior and posterior? They do, because what happens is the anterior pituitary, or what's also called the adenohypophysis, secretes certain hormones from the front portion of the gland. The posterior pituitary, which is called the neurohypophysis, secretes two other hormones from the back side of the gland. So we do find a little bit of a difference in name, more so by what hormones are secreted from each area. Okay. Again, that pituitary gland is connected to the hypothalamus by a stack called the infundibulum, and that stack is surrounded by a lot of vessels, blood vessels, capillaries around there, because it needs to be able to send a signal from the hypothalamus down to the pituitary, both a chemical and a neural signal. It has a rich vascular supply. Why? Because all endocrine organs need a rich vascular supply. Why? Because they have to take and make a hormone and put it into the circulatory system. Okay, so let me tell you what happens here. Okay, and this is going over what we talked a little bit about before. The hypothalamus senses something's not right. It's a little bit out of that homeostatic range. Okay, so as a result, there's something that needs some type of a homeostatic correction to get it back in line. So what the hypothalamus does, it secretes a chemical which is called a releasing factor. Okay, and this releasing factor goes down the area towards the infundibulum and sends the signal to the pituitary saying, this is what you need to do. It's sort of like a messenger coming from the boss saying, this is what you need to do. What happens is then the pituitary receives this signal through the releasing factor from the hypothalamus and says, okay, I'm going to send out the appropriate hormone from the pituitary. So the pituitary responds to the stimulus from the hypothalamus and secretes the appropriate hormone, puts it into the circulation. That hormone then circulates throughout the body until it comes to the target or the effector organ. Okay, and then what happens is a target or effector organ will have receptors, receives that hormone, and says, okay, boss, I know what to do, and sends out its hormones that creates some type of an effect, that produces the effect. Okay, once that everything gets back into normal, the hypothalamus senses it and shuts it off. Says, okay, we've got enough. Production is enough. Let's stop. And that's called negative feedback, like we showed in an earlier image before, and homeostasis is acquired. Let me just give you an example of this. Let's say what happens is my metabolism level is low because my thyroid hormones are low. So therefore my metabolism's low. It has some negative effects, you know, weight gain, a little drowsy, constipation, blah, 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 and I'll talk about that later on. So the hypothalamus says, I'm not seeing enough thyroid hormone going around in the blood, okay? So I'm going to tell the pituitary to tell the hypothalamus, or to tell the thyroid gland what to do. So the hypothalamus senses there's not enough thyroid hormone going around to keep the metabolism up to an appropriate level. Sends out a releasing factor, thyroid releasing factor, TRF. Okay, it's called TRF, by the way. Thyroid releasing factor. It sends that out from the hypothalamus to the pituitary. The pituitary says, I got it. The pituitary sends out then another hormone called thyroid stimulating hormone that gets in the circulation that goes to the thyroid gland. The thyroid gland says, got the TSH, I'm good. Then start to make thyroid hormone, which are called T3 and T4. T3 triiodothyronine, T4 thyroxine. And the T3 and T4, one's very active, one's less active. We don't have to go into that, but they're put out in the circulation, and that makes metabolism go faster. As metabolism goes faster, and what happens is I see now that the hypothalamus sees now there's appropriate levels of T3 and T4 in the blood. It says, okay, pituitary, we've done your job. Let's not send any more signals to the thyroid, and that stops, and now we're back in homeostatic control. So that's how the pituitary gland works with the hypothalamus, because it gets the signals from the hypothalamus, and then it lets all the other whatever target or effector organ it needs to make whatever hormone it needs to make. Okay, and again, if we look at this picture right here, if I'm looking, basically here's the pituitary. Whoop, let me use something darker here. Here's the pituitary gland, and it's still not going very dark. Okay, the pituitary gland is right here. Okay, in there, and the hypothalamus is going to be sitting right in this area, and there's going to be a little stalk that goes from the pituitary to the hypothalamus. That's a mess. Okay, but you can actually see where it's at. We've talked about that before. So the hypothalamus is sitting here. Pituitary sits down here, and it's not making any picture, and it's connected by a stalk. Okay, and that's how it gets its signal. The releasing factor gets down through that infundibulum, through the blood vessels to the stalk. You can see it here. Again, you see the hypothalamus sits right above the area of the pituitary, and the pituitary is like right behind the eyes. Okay, if you look on the picture on the left, it looks like it's temporal lobe, but it's not. It's actually sitting in the midline, right in the middle, in that hypophyseal fossa. That's where it sits, and everybody knows what hypophyseal fossa is. You've seen that before. Okay, now the pituitary, again, it has an anterior pituitary and a posterior pituitary. The anterior pituitary, or adenohypophysis, is called the anterior pituitary lobe, adenohypophysis, anterior pituitary, and it has 6 basic hormones that it makes. The first hormone that it puts out in the anterior pituitary is called growth hormone. Guess what growth hormone does? It stimulates growth. Okay, if we have a situation where a kid is growing, where do they grow? Where do the bones grow? Epiphyseal plates. It's going to stimulate the epiphyseal plate to make more bone. Okay, eventually that growth hormone slows down. If growth hormone becomes excessive and too much later on in life, it causes a significant problem. Some people get a pituitary tumor, and what happens is it puts out too much growth hormone, and their head size changes, their hat size changes, their voice changes, they get this gigantism, and what happens is the fingers get big and wide and stuff like that. Once the growth plates are closed, you don't get as much long, but they get wide, so things get big and bulky. If you think back, if everybody has had to look at and seen it one time in your life. In fact, I should make a requirement for the course. The Princess Bride. In the Princess Bride is Andre the Giant. Andre the Giant obviously had a pituitary problem with excessive growth hormone prior to the time when he reached maturity. So that's called growth hormone, obviously for growth. Okay, and it does cause size. In fact, a lot of times I remember if kids are lower than a certain percentile in their growth, sometimes they could actually give them growth hormone to stimulate their growth while the epiphyseal plates are still open. Okay, ACTH, adrenocorticotropic hormone. Basically, what happens is this is a hormone that stimulates the adrenal gland to secrete certain things like cortisol. Now, cortisol is like our natural cortisone, and let me tell you this: it is essential. You need this cortisol. If you don't have the cortisol, guess what? You die. Okay, the cortisol is something that allows us to respond to stress. So the ACTH it will stimulate the adrenal cortex. Okay, adrenal corticotropic hormone. It stimulates the adrenal cortex to secrete the hormones in the adrenal cortex, which are essential to life. Okay, TSH, we already talked about, thyroid stimulating hormone, comes from pituitary, goes to the thyroid to tell the thyroid to secrete the thyroid hormones. We have what's called FSH, okay, follicle stimulating hormone. And this is one we could talk about in female reproductive system. In the ovary, there are a certain set number of ovum, and they're in what are called follicles, little containers inside the ovary. And each month, the pituitary sends out a signal with this follicle stimulating hormone that says, okay, you follicle, you takes a certain set number of follicles with ovums in there and develops them and lets them mature, ripen. And it takes about 2 weeks, they ripen, and finally at about the middle of the cycle, that's when ovulation occurs. So the follicle stimulating hormone works during the fertile years to be able to stimulate the production or the development or the maturation of a finite number of ovum each month for ovulation to occur. And follicle stimulating is quite important in regards to developing. If there's follicle stimulating hormone is low, females will not develop the ovum. They don't mature enough, and they're never expelled, and all kinds of problems. The next hormone we have down there is called LH, and LH is luteinizing hormone. What happens is, we talked about that follicle stimulating hormone stimulates the development or the maturation of an ovum inside this ovarian follicle. Okay, what happens in the middle of the month, that middle cycle, when that ovum is matured and ripened, what it does is it works its way right to the edge, okay, right to the edge, the side of the ovary. And what happens, the pituitary then sends out this LH, or luteinizing hormone, which actually, it's called an LH surge, a big blast of LH, and that's what actually stimulates the ovulation. And what happens also then after that, where the ovum was expelled right through the wall, it's spit out through the wall. That's why some females will get, ovulatory cramping. They may get some discomfort because the ovum actually comes right through the wall of the ovum. It leaves a gap. What happens to LH helps to treat that gap, and it fills with a yellow material, which is called the corpus luteum. And that corpus luteum inside there starts to make another hormone called progesterone, which increases the thickness of the inside, or it doesn't really increase the thickness, it makes the increased thickness inside the uterus, which is made by estrogen, better. It makes it more glandular. So if there is fertilization, there's something for the ovum to stick to. To fill in that, what happens at the beginning of the month, at the beginning of the cycle, what will happen is when the FSH starts to be secreted by the pituitary, what we find is the ovary also secretes estrogen. And estrogen makes the inside wall of the uterus, the endometrium, thicker. And it's made thicker because what happens, I need a cushy place for a fertilized ovum to sit. And finally, when that corpus luteum is made and starts to secrete the progesterone goes to that thickened endometrium and makes it better, makes it more glandular, so it's a more habitable place for an ovum to stick to. Okay, if there's no fertilization, and that's sort of another story. If there is fertilization, where the ovum sticks to the inside wall of the uterus, it creates what's called the chorion. Okay, and that chorion actually secretes another hormone called human chorionic gonadotropin, which is the basis of a pregnancy test. Okay, and that feeds back to tell the brain no more FSH because we're pregnant at this time. What happens if there's no pregnancy? Then at the end of that month, what will happen is the estrogen levels drop off, the progesterone levels drop off, and the inside lining of the uterus is sloughed, and that's called menses. Okay, but we could talk about that a lot in a reproductive video. Prolactin, guess what prolactin is? Lacto means milk. Prolactin is the hormone that's secreted by the pituitary gland that stimulates the development of breast milk after birth. Okay, so that's the adenohypophysis anterior pituitary. And again, these are the hormones that are produced: the TSH, the ACTH, FSH, and LH, the growth hormone, prolactin, and also various endorphins are produced there as well. Endorphins have multiple different purposes. Okay. And basically, these are those, and there's the organs that are involved with all those hormones that are there. And I guess you see a little picture on the top and the right side. You see the little the anterior pituitary, with the front part. So the right side of the screen would be anterior, and the green part would be the posterior at that time. And all the little blood vessels that take the releasing factors from the hypothalamus, take it down that stalk or the infundibulum to the area of the anterior pituitary to tell the pituitary which hormone to secrete. Okay, and that's what we have in this image right there. And on the left side shows what organs are affected by each of those. Again, the breast by the prolactin, the adrenal cortex by the ACTH, the thyroid by the TSH, the bone by the growth hormone, the ovary and the testes by gonadotropins are also produced there. Kidney is involved, gets the ADH, and the ADH is a little bit different, and that comes from the pituitary, but that's from the backside. And then the uterus contraction, which is oxytocin, which is from the posterior pituitary. I'll talk about that in a second. This is just a picture of somebody with gigantism, where the growth hormone was excessive, and very large features, large individuals, bodies out of proportion, the head's quite large, they have a very deep voice, the teeth are usually widespread, very high cranium, all kinds of problems. They do have all kinds of physical problems because their musculoskeletal system isn't built for that size. Okay. Then we have the posterior pituitary, which is called the neurohypophysis. That's the backside, okay? And in there are two basic hormones that are produced, okay? One hormone is called oxytocin. Now, females who are in labor hate this hormone. Why? That's the hormone that during the time of labor is secreted by the pituitary to create uterine contractions. So oxytocin is responsible for causing the uterus to contract to be able to expel the baby down the birth canal. ADH we talked about in the urinary system thing. ADH is a hormone that's produced by the posterior pituitary in times when I want to conserve water. If someone's dehydrated, they don't want to urinate out a whole lot, because we know if you've gone through that, since you've gone through the urinary system, we filter a lot of fluid, over 100 liters a day, 100 to 180, 200 liters of urine per day, but most of it's reabsorbed before it even gets to the outside. Well, what happens is, let's say I need to conserve fluid. Okay, I need to conserve water because of dehydration, vomiting, diarrhea, or somewhere I'm losing a lot of water that you don't want to lose. What happens is the posterior pituitary sends out this hormone called ADH, and it makes the tubules from the ascending loop of Henle, the distal convoluted tubule, through the collecting duct less permeable, or it makes it more permeable to water, so it gets the water and sucks the water, more water out of the ascending loop of Henle, the distal convoluted tubule, and the collecting duct, so it gets it back into the system, back in the circulation, as compared to letting it stay in the tubule so it could be eliminated and out the toilet. Okay, so that's the posterior pituitary, the neurohypophysis or posterior pituitary. Okay, and that's the posterior pituitary again. Two hormones back there, oxytocin and ADH. Okay, and that's what we have for the posterior pituitary. Again, the pituitary gland, like I mentioned before, is generally under the influence of the releasing factors from the hypothalamus. They tell the pituitary what hormones to release. What are those 8 hormones should they release? Okay, and then the pituitary hormone that's released goes to another target organ that tells that other target organ secrete their specific hormones that make things happen. Okay, and that's what the pituitary does. And again, that's the pituitary, anterior and posterior pituitary, and the connection to the hypothalamus, where the neurons that with the releasing hormones are up in the neurons. The releasing hormones then cause a stimulation of either anterior, posterior pituitary to tell the pituitary, the anterior, posterior port, which hormone to release. Okay, now, let's talk a little bit about the thyroid gland. The thyroid gland is it says the largest gland in the endocrine system, but I don't agree with that. Okay, some books will say. I think if I look at the tissue itself, okay, the amount of tissue itself, it may be, okay, because the thyroid gland is there for one purpose. It's there for endocrine purpose. When I talk about the pancreas, a lot of the body of the pancreas, which the pancreas is a much larger organ, a lot of the body of the pancreas is made for something else. It's made to produce enzymes and stuff like that. But I wouldn't worry about that at all. It's an H-shaped organ, as you saw when we did the respiratory system, just below the larynx. It has two lobes, a big lobe on the right side, a lobe on the left side, and the middle is connected by a band of thyroid, which is called the isthmus, that connects the right lobe and the left lobe. Okay, and that's called the isthmus. We look at that, and again, here's the thyroid. So if you look at the thyroid here, let me change here. If we look at the thyroid, this would be one lobe here. Here's another lobe right here, and then this area right here is called the isthmus. Okay, there's the thyroid cartilage up in here. Here's the cricoid cartilage sitting right there, and we know that sits below that. Okay, and that's where the thyroid gland sees. You see the same thing over here. Here's the one lobe, here's another lobe, here's the isthmus. There's sometimes a little tongue piece that sticks up in there, but that's beside the point. Right over the area of the cricoid cartilage. Okay, so anyway, that's where the thyroid gland sits. What the thyroid does is it produces 2 hormones. One's called T4, which is called thyroxine, and the other one is T3, or triiodothyronine. Okay, and they convert back and forth between each other. One's a little bit more active than the other. One actually is more benign, and the other one is actually more active, and that's not really important to know. Just note that there's a T3 and a T4, which are basically the 2 thyroid hormones, and what they do is they regulate metabolism and energy level. Okay, so as a result, when they're higher, they'll increase the rate of oxygen consumption, increase the rate of carbohydrate, protein, and fat metabolism. So in other words, the higher the level of these T3 and T4, the faster my body is metabolizing things. Okay, they also work with growth hormone and stimulate activity in the nervous system, but that's not what we're talking about here. Again, they get that thyroid releasing factor from the hypothalamus that sends the signal to the pituitary, and the pituitary sends out that thyroid stimulating hormone. In fact, when they look at people for hypothyroidism, they will look at the T3 and the T4 levels, but they will also look at the TSH levels. Okay, that's a good screening test, looking at the TSH. If the TSH is normal, it usually means that the T3 and the T4 levels are normal, because there's no need to tell the thyroid to make more thyroid hormone. Okay. On the other hand, if the TSH levels are high, it usually means that the thyroid isn't doing what it needs to be doing, and the pituitary has gotten the signal from the hypothalamus saying, "Hey, tell that thyroid we need more thyroid hormone." So therefore, there's greater amount of TSH that's put out by the pituitary to tell the thyroid what to do. Okay. So that's called that's the TSH, and then the T3 and the T4 are the thyroid hormones. Okay. And this just shows about again, like we talked about. We have up at the top of the picture there the hypothalamus, which senses a lower metabolic rate, low levels of T3, T4, sends a signal to the pituitary. We see in the middle that the pituitary then sends that TSH in the blood to the thyroid, and the thyroid then makes the T3, T4, and the T3 and T4 do their job. Okay, and basically that's what both of these will show you. Both of these charts will show you what happens. And when I finally get to the normal level of metabolism, and my T3 and T4 levels are normal, then the hypothalamus says enough's enough, stops off its releasing factor, the pituitary. Therefore, the pituitary has no further signal to tell from the TSH to tell the thyroid what to do. Okay, a couple of things that happen with the thyroid: hyperthyroidism. Okay, and sometimes hyperthyroidism is a elevation of T3, T4, or one or both of them. Okay, what we see a lot of times in people with hyperthyroidism is it's called Graves' disease. Graves' disease, and this is where the thyroid is going really fast. Okay, and one of the things that they frequently get is what's called a toxic goiter. They'll get this big lump in their neck. Okay, and I'll show you a picture of a goiter in a second. What we see with hyperthyroidism, obviously, is that the metabolic rate is off the wall. It's much harder. It's much higher. As a result, the body is doing a lot more metabolic work. What's the process, or what's the problem? We're using up the nutrients faster than we really need to, and as a result, there's weight loss. Usually, they sweat a lot. There's excessive perspiration. They always feel hot, because metabolism does what? Produces heat. Okay, sometimes muscle weakness is associated with that. Emotional instability is not unusual in these individuals. They frequently get what's called EXOPHTHALMOS. These are the people that look like they have these big bulgy eyes. They look like frog eyes. They're sticking out of their head. They're way out. Okay, and it's called EXOPHTHALMOS. And what happens is the hyperthyroidism actually creates I can't really say a water behind the eyes, but a gel behind the eyes which actually pushes the eyes out a little bit, and that's what's called EXOPHTHALMOS. They get that goiter. Okay. And again, they just have, sometimes it's because they have too much thyroid stimulating hormone. Sometimes the pituitary goes haywire and it hasn't gotten a signal from the hypothalamus, and just for some reason abnormally sends out too much thyroid stimulating hormone. That might be in what we call a thyroid adenoma. Maybe that thyroid adenoma, which is a benign tumor, is actually making the thyroid, or making the pituitary secrete too much TSH. It has to go somewhere, and it goes to the thyroid, and the thyroid says, okay, I make much more T3, T4, when it doesn't have to. And that's one of the reasons why we get that hyperthyroidism. One of the ways that they treat this is they either try to use drugs that may block the production of the T3, T4, okay, surgically remove part of the gland. Sometimes they'll go in and just cut off a chunk. Okay, or they could actually administer what's called radioactive iodine. Okay, but give them radioactive iodine. What happens is the thyroid hormones T3 and T4. Guess what a large part of the T3 and T4 are? Yes, iodine. So what happens is they need the iodine. The iodine goes to the area of the thyroid, and because it's radioactive, it burns some of the thyroid away because of that radioactivity. Okay. One of the things, if you look at salt, sometimes in the past, when goiters were a problem, or when thyroid problems were a problem, a lot of times they used to iodize salt. They would put salt in salt, or iodine in salt, so that way people would salt their food. Now people aren't salting their food nearly as much, so it's not as big of a deal. Okay. Now this is that EXOPHTHALMOS. They look like what happens if I look at the eyes, the colored part is called the iris, okay, and the white part is called the sclera. Normally, if you look at someone, you don't see the sclera above and below the iris. In EXOPHTHALMOS, because the eyes are pushed forward, you actually see sclera. You see white above the iris and you see white below the iris, and that's called EXOPHTHALMOS. Okay. And this is a goiter. Okay, this is a goiter. This is on one side. You see it on the. It would be on the right side of the image. It would be the left side of the neck on the left on the left image. And sometimes you'll just get one lobe of the thyroid that's enlarged. Okay, I know I have hypothyroidism, and I have one of the lobes has a nodule in it, and that nodule just isn't making any thyroid, which is different from hyperthyroidism. The thyroid is a little bit low. Anyway, the one on the right, you can't miss that. You know, that's a huge goiter. That's a huge thyroid gland. Okay, so that's what those are. Then you can see these big lumps in the neck as well as the hypothalamus and stuff like that. Hypothyroidism is exceptionally common. I'd be surprised if somebody in the class isn't hypothyroid, or if somebody in their family isn't hypothyroid. It's an exceptionally common thing. Okay, I know maybe about 10 years ago. I know with cardiac problems, with heart-related problems, they always look at the thyroid. My doc would always get thyroid tests, and all of a sudden say, "Oh, geez, your TSH level is high," which means that my T4 and T3 levels were low. Okay, so I looked a little bit more, and sure enough, I was hypothyroid. They went in, I had an ultrasound, showed me I had a little nodule on the right lobe of my thyroid, which has been stable over the past 5-6 years, so there's nothing going on. What happens with hypothyroid, they have a tendency to have a little bit of edema that forms in the legs, you know, in the shins and stuff like that. Again, the blood levels of T3 and T4 are low. Because the metabolism is low, they have a tendency to gain more weight. Their body reactions have a tendency to be more sluggish, more constipation, where in people with hyperthyroidism, they have a lot more diarrhea or active because their GI system is going faster. In hypothyroid, hypo means low, then what happens is they're more constipated, lower metabolic rate. They sometimes get to what's called myxedema, which is a real profound. They get really significant anterior leg swelling, and the symptoms are more severe. But that's with a real significant hypothyroidism. And in infants, okay, infants are actually, if a kid is born with hypothyroidism, it's called cretinism. Now the problem with cretinism is the big thing about it is it causes mental retardation. Okay, so kids who aren't identified as having hypothyroidism as a newborn, it's some problems. Nowadays, it's all newborns are tested for their thyroid, just to make sure that they're not cretins. Because again, the kid, you don't know about that mental retardation until they get a little bit older. But so therefore, they will check the thyroid at the time of birth or shortly after birth, just to make sure that the thyroid is functioning normally. But cretinism develops with mental retardation, impaired body growth. Some areas of the body will overgrow, some will grow less. They have a tendency to have low body temperature. Their bone formation is abnormal, which results in certain types of malformations. Okay, and again, this develops. And a lot of times what happens, they'll look at the mom and measure her levels of thyroid function when she's pregnant, just to see, because some of that will be carrying over towards the baby. Okay? Again, hypothyroidism, you can look at this and read all these things, tiredness, puffy eyes, swelling, hoarseness, persistent dry sore throat, difficulty swallowing, slower heartbeat, menstrual irregularities in females, heavy menses sometimes, infertility, constipation, blah, 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 muscle cramps, blah. And you can read all those things that have a tendency to go along with hypothyroidism. Hypothyroidism is a heck of a lot easier to treat than hyperthyroidism. In hyperthyroidism, you either burn part of the thyroid away, you cut part of it away, or you take some medications which are relatively toxic. And hypothyroidism, you know what you do? You give them Synthroid. You give them an analog or an artificial type of thyroid medication, and they do that. And when they give the medication, they gradually increase the dose until finally the TSH levels come back down to the normal, and they know everything's fine. Okay, so basically I take Synthroid every day, and it's been adjusted a couple times, but not a big deal. Okay, and this is a thyroid scan where they can actually use radioactive material to see how the thyroid's functioning. These are called hot areas and cold areas. If there's a nodule, if the nodule's not working, that area would be white, would be cold. The areas that are darker are called hot, where maybe the thyroid's working a little bit too fast. Okay, behind the thyroid, like I mentioned, are the parathyroid glands. Okay, and there's 4 to 8 small nodules that are back there. They're hard to differentiate parathyroids from thyroid. Okay, tissue back there. And what they do is their purpose is to regulate calcium. Okay, and calcium homeostasis. So what they do is they secrete 2 things, either a parathyroid hormone or PTH. Okay, or calcitonin. What happens is with parathyroid hormone is secreted by the parathyroid glands. Okay, when the serum levels of calcium go down. I mentioned this before. If my serum calcium levels go down, what happens, I need it more for muscle contraction, heart contraction, nerve conduction, things like that. That's where I need the calcium more than in the bone. So what happens is the parathyroid glands, under the stimulus of you know what they're told to do, the parathyroid glands sense that low levels of calcium, and what they do is they secrete what's called parathyroid hormone. And the parathyroid hormone does a couple things. It takes the calcium out of the bone and sticks it in the blood where it's needed better. Okay, so it takes it from the bone and puts it in the blood. Also, what the parathyroid hormone does, it goes to the GI tract and says, okay, gut, I need you to absorb more calcium through the wall of the gut. So it takes more, absorbs more through the wall of the gut. Also, it goes to the kidneys and says, okay, kidneys, we're going to save the calcium, so don't excrete it. Take it out of the tubules and remove it from the tubules, and let's conserve it. So that's what the parathyroid hormone does. If my calcium levels in the blood are too high, the parathyroid gland secretes another hormone called calcitonin, and the calcitonin shuffles the calcium in the blood into the bone. Okay. In fact, some people with severe osteoporosis, they tried to treat it with calcitonin supplementation, and it was helpful in some, but sometimes it was expensive and it was hard to manage. Okay. And this is looking at the back of the thyroid, and like there's little dots back there that are parts that look like the thyroid, but they're the parathyroid glands. Okay. And again, the parathyroid gland does things when the serum calcium level is low. It takes it out of the bone. It reduces it from the bone. It decreases the kidney excretion, and it causes the gut to absorb more. Interesting thing enough as well is what happens is vitamin D is also helpful in strong bones. Guess what I need for the vitamin D to be activated? Of course. The parathyroids with the parathyroid hormone and stuff like that, I need that calcium to activate the vitamin D. So in other words, the formation, vitamin D in the body is in an inactive form, and the sunlight and calcium convert it into an active form. So I need the calcium. So sometimes for vitamin D deficiency, they might give certain things that will actually get more calcium in the blood. Okay. And that's just looking at it again, looking at what the parathyroid glands do and how they affect the kidneys, the liver in regards to the formation of vitamin D, because again, to transform an inactive form of vitamin D to an active form requires vitamin D, and vitamin D is reliant upon calcium to be able to do that. Small intestine, increased absorption, decreased excretion from the kidneys, and then take it out of the bone. Okay, and that's just what that thing shows. Hypoparathyroidism. A lot of times, the biggest reason why there's hypoparathyroidism, hypo again, low thyroid function, is because there's either an injury, or they've done a thyroidectomy or partial thyroidectomy, or they've removed the thyroid because of a cancer or a tumor, and as a result now the parathyroids are gone, and as a result now there's low circulating levels of calcium. Why? Because there's nothing to make the parathyroid hormone to bring the calcium out of the bone. Okay. Also, it causes certain problems, such as what happens is, remember how the calcium is involved in regards to going across, binding to the troponin to let the tropomyosin interact and stuff like that. What happens is, what we find is that the calcium stays in there, and it causes the muscles to go into spasm and stay contracted, which is called tetany. When people have thyroid surgery, one of the things they look for them afterwards is for tetany. And what they do is there's a couple ways. If you tap, when people are going into tetany, and this, you know, with the low levels of calcium in the blood, if you tap over the cheek, their cheek will contract up, or if you tap over their eyes, there's just different ways they could check for tetany and stuff like that, muscle twitching and spasm and tetany with low calcium, because of low parathyroid hormone. Hyperparathyroidism is usually due there's a benign tumor in the parathyroid, and as a result it increases the parathyroid, then causes things like osteoporosis, because I'm taking the calcium out of the bone and stuff like that, increased susceptibility to fractures and stuff like that. We have a lot of calcium deposition in the kidneys, and they get tumors. Okay, not tumors, but stones. Okay, hyperparathyroidism, what they call them, stones, moans, groans, and psychiatric overtones. These people sort of are a little bit mentally crazy. They end up with stones in their urine. Their bones are become osteoporotic. A lot of abdominal cramping and pain and stuff like that. So that's because of hyperparathyroidism. Okay, the adrenal glands. The adrenal glands are on the top of the kidneys. They're also called the suprarenal gland. Okay, and they sit right on the top of the kidneys. They look a little different. The one on the right is a little bit different than the left. Why? Because the right kidney we know is a little bit lower than the left kidney and stuff like that. And they have two sections to them. The outer portion is called the adrenal cortex, And the adrenal cortex makes work various types of steroids and cortisol, which are essential to life. The inner portion is called the renal medulla, and the renal medulla creates sympathomimetic type materials. Sympathomimetic they mimic sympathetic, because sympathomimetic materials means that they have sympathetic nervous system activity. Epinephrine, again, increases the heart rate, raises the blood pressure, opens up the bronchioles and the lungs and things like that, okay? So the adrenal cortex is exceptionally important, okay? And this is just like a picture you see with the kidneys, and you see the adrenal cortex on top of the left and the right. There's the right kidney, which is lower, and the adrenal cortex is more pyramidal shaped, where the one on the left is a little bit higher and it's a little bit more rounded at the top, okay? You can see the aorta right there with the renal arteries going, and just above the renal arteries, you can see the superior mesenteric artery coming across the front, which you know about that, and you can see some adrenal arteries that come up to the. There's usually three. There's a superior, middle, and inferior adrenal arteries, and basically what they do is we know that that it's an endocrine gland. So what does endocrine glands need? A very vigorous, robust blood supply, because they put their hormones into the circulation. Okay. Some of the hormones that we get in the adrenal cortex are called mineralocorticoids, glucocorticoids, or gonatocorticoids. Okay, and let's talk a little bit about those, what those are. Okay, and basically the adrenal cortex again releases glucocorticoids, one of which is called cortisol. Cortisol, like I mentioned before, is essential for life. Okay, is essential for life. It helps us to respond to stress. Okay, helps us to respond to stress, and so it's an essential essential hormone by the adrenal cortex for living. The other one is a mineralocorticoids. Okay, and the mineralocorticoids are aldosterone. We talked about aldosterone in the renal or the urinary system problem or section, where what we were talking about aldosterone that's actually stimulated to be released from the adrenal cortex by angiotensin II, which you should know by now, actually goes to the kidneys and says, kidneys, save sodium and save water. Okay, and that's what the aldosterone does. Increases volume back into the body and increases intravascular pressure. And then we also have sex hormones. Testosterone is not just made in the area of the testes, but also we make some testosterone as well in the adrenal cortex. And there's my adrenal medulla with the epinephrine and norepinephrine, like we talked about before, which have sympathetic activities. Okay, this is looking at again that relationship between the hypothalamus, to the corticotropic releasing factor is produced by the hypothalamus that goes to the pituitary. The pituitary then secretes that hormone called ACTH, which we mentioned before, and that ACTH then goes to the area of the adrenal cortex that causes the release of adrenal cortical hormones. Okay. So what do we know? Mineralocorticoids, we talked about that before. Aldosterone is important homeostasis of sodium as well as potassium. It conserves sodium. Again, if I need to increase volume, okay, I want to save the sodium. Why? Because again, where sodium goes, water goes. If I conserve sodium, I'm also going to conserve water. Okay, if I conserve water, I have more fluid volume to stick inside the vessels to increase vascular volume. Okay, so therefore aldosterone will help to reduce urine output. Why? Because in the ascending loop of Henle, in the proximal convoluted tubule, or in the distal convoluted tubule and the collecting duct, it's sucking more of the water out of the tubules and putting it into the peritubular capillaries, like we talked about before. Well, it conserves the sodium, it gets rid of potassium. Potassium and sodium always go in the opposite directions. Okay, cortisol. Cortisol regulates a lot of things. It regulates the consumption of glucose in the blood, protects against blood sugars and stuff like that, stimulates the breakdown of fats, all kinds of stuff. It's essential for me to respond to stress. Okay, John Kennedy. Okay. People say, oh yeah, he took steroids. Yes, he did. He took cortisol every day. He had something called Addison's disease. Addison's disease is where the adrenal cortex is hypofunctioning. It's not working. He could not make his own cortisol. Okay, he was actually a pretty sick puppy. Okay, and he could not make his own cortisol. Had to get injections, cortisone type injections every day to keep his cortisol levels up, or his body cortisone levels up. But it's important in regards to stress and stuff like that. This is one thing. If you have a family member who's taken some type of a steroid for like rheumatoid arthritis or other types of inflammatory arthropathies and stuff like that, they frequently take prednisone or something like that, and they take it in a high dose over a long period of time. It actually makes the adrenal cortex stop working. So even though the adrenal cortex may be making some of that. They give that cortisol because the cortisol, or the prednisone, or something similar to that, triamcinolone, whatever the analog is of the cortisol. They give that to decrease inflammation. It's an anti-inflammatory. But what happens is when they give high doses over a long period of time, it shuts down the adrenal cortex. Also, it also decreases the immune response. People who are on high dose cortisols or cortisone, their response to illness is less. Their blood sugar rises up. Blood sugar frequently goes off the wall, and then what happens is it also causes my immune response to be decreased when I have high levels of the cortisol. Okay, if I have low levels, it doesn't work. Okay, so anyway, the cortisol regulates the concentration of glucose, protects against low blood sugar because it increases. So the cortisol keeps the blood sugar at a constant level. Too much of that cortisol, because they're getting the exogenous cortisol from the outside, the blood sugar goes off the wall. Okay, so that's just a little about what the glucocorticoids are. Essential to life. Essential to life. That's why when people have taken high dose corticosteroids, prednisone, triamcinolone, and stuff like that for a long period of time, they don't just stop them abruptly. There'll be a big thing on the bottle that says, do not stop this immediately. They taper it off over maybe 3 to 6 months, very slowly decreasing the dose to get them off of it, and that allows the adrenal cortex to start working again, which becomes a real significant problem. Okay, so that's the cortisol. The cortisol goes with the ACTH. Again, the hypothalamus sends a signal to the pituitary by the corticotropin releasing hormone. Then the pituitary sends a signal out to the ACTH that goes to the adrenal cortex, and the glucocorticoids, such as that cortisol, is produced. And the cortisol, again, the natural body cortisol material. Okay, sometimes people have an adrenal cortex that works too much, and this is called Cushing syndrome. They can get Cushing syndromes because they're taking large doses of cortisone, but sometimes the adrenal cortex is just working more than it should, and that's called Cushing syndrome. Okay, so the adrenal cortex is making far too much cortisol, and as a result, it creates a problem. It can either be because of a tumor in the pituitary or in the adrenal cortex or whatever. They have a number of things that occur with them. Their face gets really big and round. It's called a moon facies, or moon face. It's big and round. They get in the back between their shoulder blades, they get this large fatty hump back there. It's called a buffalo hump. Their abdomen, they get these stretch marks, purple stretch marks. Their trunk is big, but their arms and legs are very thin. A lot of fatigue, high blood pressure. Females get hirsutism, or facial hair. And what they have to do is sometimes they have to go, and if it's because of a tumor, they'll actually take out part of that tumor from the adrenal cortex. And this is some of the things that you can see from Cushing syndrome. You could read it on your own, a number of the various types of things that will occur with Cushing syndrome. And this is that buffalo hump, like I talked, very appealing, isn't it? That big hump back there, that's called the buffalo hump, and they frequently see that with Cushing syndrome where there's too much cortisol because we have a hyper excretion of the cortisol because of excessive activity of the adrenal cortex. And this is that moon facies, how the face gets really round, like the face of the moon. Okay, you can see that on the two on the right. And this is hirsutism. And this is facial hair that develops in females, okay? So you see a little beard and a little mustache and stuff like that. And this happens a lot. And the reason why it happens is it also stimulates an excessive release. The cortisol stimulates an excessive release of testosterone. And so the testosterone levels in females goes up and it causes that facial hair to be made, okay? So that's a problem with what's called Cushing's syndrome. Addison's where it's decreased, okay? The adrenal medulla, what happens, makes that epinephrine and norepinephrine. And what happens is that makes things go faster, just like we talked about with the nervous system. How that sympathetic nervous system makes the heart rate go faster, the blood pressure go up, gut motility, the peristalsis decreases actually. And, we talked about the breathing gets faster when the sympathetic nervous system gets stimulated. The bronchioles dilate a little bit more, and that's from the epinephrine. When we have the adrenal cortex, I should have put this one before the adrenal medulla. This is Addison's disease. We talked about that before, and that's when the adrenal cortex is not working enough, okay? So we don't have enough of the cortisol that's produced in the adrenal cortex, and it might be because of an autoimmune process and stuff like that. And what happens is they can't deal with internal and external stress. Not just like, oh boy, I got a test next week, I'm nervous. No, it's they can't respond to physiologic stress, and their body will actually shut down, and they may die from that. Okay, there could be problems with their sodium and potassium metabolism in regards to the levels and stuff like that. They get a depletion of sodium and water. Why? Because again, the adrenal cortex isn't working. They also don't make aldosterone, which actually conserves the sodium and the water. So now they excrete too much. They get muscle weakness, anorexia or loss of appetite, a number of GI symptoms, fatigue. Their blood sugar now goes down. Again, if I have high adrenal cortex activity, there's too much cortisol, which raises the blood sugar too high. But if the adrenal cortex isn't work, the blood sugar levels go down. So they get hypoglycemia, low blood pressure. Why? Because they're eliminating too much sodium and water out the urine. There's no aldosterone. Hyponatremia, again, because the sodium is being eliminated. Hyperkalemia, because again, if I'm getting rid of the sodium, what do I save? Potassium. So they have to treat that with replacement therapy by supplemental cortisols, okay, or cortisone to keep them alive. Okay, this is one of the things that they see. A couple things that they see with Addison's, which I think is sort of neat. The hand on the left side, the darker hand, and the hand on the right side. This is very classic. What happens is people with a Addison's disease, with that low level of activity of the adrenal cortex, they get a bronzy tan. They don't have to go to a tanning booth at all. They get this bronzing tan, which you see on the left hand as compared to the other one that's more to the right. So they get this bronze discoloration. They used to always say that John Kennedy used to have, they thought, oh, he's a rich kid, lives in Hyannisport, has a big boat, families of big important people and stuff like that. He probably has his own tanning booth. He didn't need it. He was already bronzed because he had Addison's disease. Okay. Also, if you look at the picture on the right, you see the gums, those little darkish areas around the gums. That's also what they see with Addison's disease, besides those other clinical things we talked about before. So they also see that with Addison's disease. Let's talk about the pancreas a little bit. The pancreas, we know, and we probably don't have to spend much time on that. We know it's inferior and posterior to the stomach. We know that the head sits in that C loop of the duodenum. We know it has both endocrine and exocrine function. What happens, the exocrine with the amylase, lipase, and the other enzymes in the endocrine from particularly, that's TION, endocrine function with the insulin and glucagon. The insulin's made in what are called the islets of Langerhans, okay? And what happens in the islets of Langerhans are two types of cells. Alpha cells, and alpha cells produce something called glucagon. Glucagon will actually raise the blood sugar. In the beta cells of the islets of Langerhans, they make insulin. Insulin will lower the blood sugar. Okay, and you need both of them to be able to regulate the levels of blood sugar. So in other words, what we find is, and I could speak for about an hour just on the regulation of blood sugar, that when my blood glucose goes up, the pancreas then secretes the insulin to bring it down, and frequently it overshoots, and sometimes little glucagon's needed to get it back up into a normal level. Particularly in early diabetic patients, that happens. And again, that's a picture that we saw before. You see the pancreas sitting there in that C loop of the duodenum. Okay, and this just looks at the alpha cells and the beta cells. Alpha cells for glucagon, beta cells for insulin, and these islets of Langerhans. That's all that really basically shows there. And we talked about diabetes. Diabetes is basically, there's a type 1 and a type 2. Type 1 diabetes is usually autoimmune. Okay, they used to say it was child onset, but that's not appropriate anymore. You could have it occurs in adults, but it's insulin dependent diabetes mellitus. And the reason why is what happens, those beta cells and the islets of Langerhans are attacked by the autoimmune response that stops them from working. So the beta cells don't work anymore and they don't make insulin. Okay, and that's the problem. That's why people with diabetes type 1, they have to be treated with insulin, because they can't make insulin because the beta cells are gone. Type 2 could be a lot of reasons. There's like a million different reasons why they have that. It's a non-insulin dependent diabetes. They may give them insulin and stuff like that, but basically there's a lot of things. Sometimes the receptors for insulin on the surface of cells don't work. Sometimes the body just makes too much much glucose from scratch, all kinds of things. So the body is frequently insensitive to insulin for one reason or other, or they're making too much glucose, and that's called type 2. And they could treat it with a bunch of other agents, oral agents, weight reduction, diet control, and stuff like that. Okay, so that's just a little bit about some of the symptoms with type 1. Polyuria means that they have to urinate a lot, and the reason why they do is because there's more glucose. If there's a high level of glucose in the blood, remember we talked about in the urinary system that most of the glucose is taken back out of the tubules and put back or reabsorbed. Okay, so I could reuse it again. However, what happens if the levels of glucose are really high, I end up with more being spilled over into the urine. Okay, and when it's spilled over into the urine, they get glucose in the urine, which makes it more concentrated, which results draws more fluid, more water with it, and results in polyuria or excessive amounts of urination. They have abnormal thirst. Why? Because they have abnormal urination. They urinate more, so they have to drink more to make up for the water that they lose. And also, there's usually an increased level of hunger, which is called polyphagia. Sometimes there's a rapid weight loss in that, irritability, stuff like that. So these are vague symptoms that you get with type 1. And type 2, basically, there could be a lot of things: excessive weight gain, crazy diets, stuff like that, drowsiness, itching, stuff like that. But they have to evaluate in regards to if it's type 1 or type 2, and they can do it a number of different ways. Down at the bottom it says skin infections and slow healing, and what we find in both type 1 and type 2 diabetics is it interferes with their ability to fight infections. Also, type 1 and type 2 diabetes have significant effects on the vascular system and on the eyes and on the nerves. There are a couple of areas that are significantly involved with diabetes. That's why they want people who are diabetic, whether it's type 1 or type 2, to have really good control. It affects the eyes. It causes hemorrhages and fluid that leaks out called exudates inside the eyes, which then cause blindness and stuff like that. It causes the nerves to swell. Glucose gets inside the nerve, causes the nerve to swell because it draws fluid in with it, and it damages the nerves, and they get what's called a neuropathy. They lose sensation. It starts from their toes and works up their legs, so they stop feeling, which results in the fact that they can't feel trauma to their feet. They frequently get ulcers or sores, and these ulcers and sores frequently don't heal. Why? Because they have a difficult time mobilizing, getting white cells there to fight the infection. So it's a mess. Destroys the kidneys, because what happens is the kidneys, the biggest reason for renal failure in the United States is diabetes. Okay, it destroys how the kidneys work. Also, it destroys the blood vessels. It makes the blood vessels narrower. So if somebody does have a wound or an ulcer that's in their foot, they don't get the blood supply to that area to be able to heal them, which is the reason why many diabetic patients go on to end up with what? Amputations. Okay, because they get infections that can't be healed. They get a wet gangrene. They can't heal it. The infection involves bone, all kinds. I've seen some nasty infections. And these are some of the diabetic complications: hyperglycemia, glycosuria, but the ketoacidosis, we already talked about that. The ketoacidosis, where now I end up with ketones because I can't use glucose as an energy source. I use fats, and the byproduct, the waste products of fat breakdown, are ketones. Ketones are acidic. They get inside the blood. They cause a change in the pH of the blood, and they may cause a diabetic coma, because as the ketones start to build up. Or insulin shock. Insulin shock means that what happens is now they get too much insulin, and that actually makes the blood sugar go low. They're much more likely, people are much more likely to die from low blood sugar than they are from high blood sugar. Okay, high blood sugar takes a while. You will die from high blood sugar, but it takes a little bit longer time. People with low blood sugar, they'll go into a diabetic coma, okay, and the diabetic coma will cause brain death. So as a result, they're much more likely. And there's an adage in medicine: it's better to be a little bit too sweet than too sour, which means that if you don't know if their blood sugar is low or their blood sugar is high, you give them sugar. And you give them the sugar, because if it's a little bit high, guess what? You'll deal with that. But if it's low, it'll kill them. Okay, so that's a little bit about diabetes there. Pineal gland. Who cares about the pineal gland? Nobody knows much about it. It's small, very small piece in the posterior portion of the brain, or in the inferior portion of the brain, right by the third ventricle. Okay. Function is sort of up in the air, but does secrete melatonin, and melatonin may be involved with some ovarian activity, but it's also involved in sleep. So who cares about the pineal gland? Okay. Again, when we have problems of the endocrine gland, it's sometimes because they make too much hormone, or they make too little. They're either under-secretors or under-producers, or over-producers or over-secretors, okay? If they're under-producers, basically the treatment is they just give them the hormone replacement, okay? Some of it might be genetic. After surgical removal, they take out part of a gland, or the hormones somehow aren't made correctly, okay? If they're overproducers, a lot of times the idea there is just take out the extra gland or use something to stop it from working. This is a little bit about the pituitary with that growth hormone. Again, the picture that we showed before. What happens if there's an absence of growth hormone, then they have a short stature. If there's too much growth hormone, gigantism. We talked about ADH in regards to electrolyte imbalances. If there's too much ADH, what happens? You conserve too much. If there's too little ADH, in fact, when there's too little ADH, okay, it creates another condition called diabetes insipidus. And diabetes insipidus has nothing to do with glucose, but they just urinate out tremendous amounts of urine. Why? Because there's no antidiuretic control anymore. No more ADH. Okay. Adrenal medulla. One other thing in the adrenal medulla I might mention is sometimes they get a tumor. It's called a pheochromocytoma. It's not a malignant tumor. It's a benign tumor. But these pheochromocytomas, what they do is they're in the area of the adrenal medulla, and they make too much epinephrine. As a result, what happens is the blood pressure sometimes just goes crazy, just goes off, and their pulse rate, their heart rate goes off the wall. And these people have almost like these adrenal crises where there's so much sympathetic activity. They get very anxious, they become very fearful, palpitations, headaches from the increased blood flow to the head, visual blurring, muscle spasms, stuff like that. And the idea there is sometimes they could actually, in fact, pheochromocytoma, they frequently have to take it out, okay? But that's what the pheochromocytoma basically is. A couple oncological things, and we talked about this before, is pancreatic carcinoma. The problem with pancreatic carcinoma, again, it's a poor prognosis. The survival rate's very low. And the reason why its survival rate's very low is because what happens is by the time people usually get symptoms with pancreatic carcinoma, it's usually well advanced. And if they do something with it, if it's amenable to surgery, they take out almost everything. Almost everything goes. It's called a Whipple, a long procedure, and they just take out everything in the kitchen sink. Okay. Some of the things that have been associated with pancreatic carcinoma: smoking. Various chemicals, occupational chemicals have been linked to that. Diets that are high in fat, people who have a heavy coffee intake. It turns out that the number of people that I know who had pancreatic carcinoma and died, most of them weren't smokers. I don't know. So anyway, that's that. Pituitary tumors, most of them are non-malignant, but they do have invasive growth. They cause all kinds of crazy things, gigantism, all kinds of other problems, because we know that there's those 6 hormones that are produced, or there's 8 hormones, 6 from the anterior, 2 from the posterior, that are produced by the pituitary gland. Lots of things. Headache and blurred vision. Why do you think they have blurred vision and headache? Because that pituitary sits in the hypophyseal fossa. And what's the hypophyseal fossa just posterior to? The optic chiasm. So they frequently put pressure on the optic nerve because the tumor is letting them bulge outside that hypophyseal fossa, and they put pressure on the optic nerve, which comes right next to the pituitary. Okay, they could look at and identify it by CT scans, X-rays, and stuff like that. Surgery to remove it. Okay, thyroid. There's all kinds of cancers. Thyroid cancers are relatively amenable to surgical treatment and chemotherapy. They usually do pretty well, okay, in most cases. If there's a hyperthyroidism, medications or surgery. Hypothyroidism, just giving them a thyroid analog, something that's like the thyroid medication. It's called Synthroid, okay, and they could give them that. Levothyroxine, okay, they give them that. Nodules, thyroid nodules are really large. If they're causing a problem, they just take them out.